Good afternoon, everybody, and welcome to our Center for Practice Excellence speaker series. It's our inaugural session for the 2020-2021 academic year, and it's my pleasure to welcome you. My name is Zubin Austin, and I will be introducing our facilitator for today's session, Annalise Mathers. Thank you so much for joining us, and let me turn it over to Annalise to introduce our speaker for today.
Thank you, Zubin. Thanks for the introduction, and echoing Zubin's comments that it's really great to be back hosting these sessions for the remainder of 2020 with everyone. So jumping right into it, our presenter for today is Sean McKelvey, and he will be presenting on type 2 diabetes remission, implications for pharmacists. After the presentation, we'll have our discussant, Lori McCallum, provide initial comments, reflections, and questions on Sean's presentation. We'll then open up the session to you, our online audience, for question and answer. Please feel free at any point to type your questions into the Zoom chat box function in the bottom right-hand corner of the screen, and we'll get to them after the presentations. So to begin, let me introduce Sean McKelvey. So Sean is a pharmacy graduate from the University of British Columbia and a recognized leader in pharmacist practice change across Canada. Sean and his colleagues have been acknowledged numerous times for innovative programs, including the Canadian Pharmacists Association Patient Care Achievement Award for Innovation and the BC Pharmacy Association Ben Gant Award for Innovation. In 2008, Sean was awarded the prestigious CACDS Len Marks Award, which recognizes an individual for demonstrating outstanding dedication to the advancement of pharmacy. Sean is currently the CEO of the Institute for Personalized Therapeutic Nutrition, IPTN, which is a multidisciplinary collaboration between researchers, academics, physicians, pharmacists, and allied healthcare professionals. Please welcome me in joining Sean, and I'll turn it over to you now.
Thank you so much, Annalise. I really appreciate it. And thank you, everyone, for providing me an opportunity to update you on an area that I am particularly passionate about. I think there's exciting opportunities in the future for pharmacists. And so I'm just going to jump right into it to talk to you about where pharmacists can fit into type 2 diabetes remission moving forward. So just to get things started in terms of disclosures, I have no financial disclosures. The IPTN has no connection to basically any industry whatsoever, whether it is a for-profit or food industry, pharmaceutical industry, any of that kind of thing. I've just put down my dietary preferences just so that you kind of know where I'm coming from. Let's get this forward. There we are. So setting the stage, the IPTN is a not-for-profit organization that is national in focus. We are currently applying for charitable status, and so we're looking forward to having that early next year. We are diet agnostic, so it's not about a particular dietary intervention. Our focus is really on clinical outcomes. And really what we are doing is promoting an interdisciplinary collaborative model that is integrative in the way that we approach the implementation and the ongoing support of patients who choose remission as their target. The key message that you will hopefully get from this talk is that therapeutic nutrition requires clinical oversight, requires the entire healthcare team working together to prevent predictable adverse events. And this is really the key aspect that I will continue to reinforce over and over again, is the important role that pharmacists will play in terms of safety and supporting patients who choose these approaches. And the key thing is that it needs to be personalized, and there are a number of evidence-based approaches that are in play, and I'm going to describe a couple of them during my talk. So our mission is really simple. We are preparing health practitioners to safely prescribe therapeutic nutrition. We have 4 strategic priorities: research, so multidisciplinary research, trying to narrow the research to practice gap. We also connect community of interest. So we have an online community of practice that has close to 2,000 members in it. We train healthcare professionals, as I mentioned, that's our kind of key focus. And we also provide a lot of supporting tools, resources, and also technology. So we work with a number of organizations in Canada as well as in other places around the world to make sure that health professionals have the tools they need to be able to deliver therapeutic nutrition services. So you might be asking a question, what is therapeutic nutrition? I've never heard of it. So it's an individually tailored nutritional intervention. So it's really targeting underlying metabolic related dysfunction and trying to overcome that through the use of nutritional interventions. So why are we doing this? Basically, we are tackling a global problem. We have a global problem of nutrition overload. As you can see, this is from 2014, where it looks at the level of obesity around the world. And as you can see, it's quite significant. In Canada, we're looking at about 63% of the population that with obesity or overweight. So it's quite a significant issue, but it's really only just the tip of the iceberg in terms of metabolic health. And diabetes is actually one of the key conditions, as you know, is sort of the granddaddy of metabolic conditions with a number of different factors that representative of metabolic syndrome. But what I really wanted to point out here was just the fact that it continues to grow quite rapidly over the last 20 years. We're looking at 11 million people across the country with diabetes and prediabetes. The vast majority of them are type 2s. And so we're dealing with a metabolic issue that is having significant health, social, and economic impacts on the country. Roughly $16 billion was the cost last year to address the challenges of diabetes. And when you look at the future, there was a study that was done out of Alberta that predicts that roughly 50% of the Albertans are going to develop type 2 diabetes in their lifetime if they're born after 1997. And unfortunately, in the First Nations community, it could be as high as 80%. So this is equivalent to a pandemic that we're having to deal with. And it's going to require ongoing and new approaches. And one of the great things is that there is a lot of work being done on type 2 diabetes remission. In fact, we just had a conference this last weekend. It's the first conference in the world on the topic of type 2 diabetes remission. And really what we are now talking about is moving from this concept of management to remission, and how can we support patients who are interested in achieving that, delivering evidence-based approaches that have provide multiple different options, and most importantly, provide patients hope that they haven't had previously. So let's talk a little bit about what remission definitions are. It's actually still very much debated out in the world of type 2 diabetes, because remission is a relatively new concept. It's really only about the last I guess it's really around the last 9 years. A lot has happened in the last 5 years, but let's just look at kind of the definition. So you can see that there's the Look Ahead study provided two different definitions, partial and complete. The American Diabetes Association added the concept of prolonged remission. These were primarily related to bariatric surgery. We're now looking at dietary interventions that can be used and achieve this. And the DIRECT study, which I'm going to speak to a little bit, has a slightly different definition where they look at hemoglobin A1C under 6.5 for 2 months or more with no diabetes medications. And this is the key point that I wanted to focus in on, was that we're talking about no diabetes medication. So if we have patients who are on diabetes medications, how do they get off? We have not trained healthcare professionals on how to do that. How do we get someone off of, for example, 150 or 200 units of insulin safely? So I'm going to talk about the role of the pharmacist as it relates to that. But I first want to talk about remission and the fact that we've known for close to 30 years that type 2 diabetes remission was possible. So bariatric surgery, as I mentioned, we then identified that very low calorie diets actually mimic the early benefits of it. So isn't it interesting that it's not actually the surgery, but the dietary intervention that is actually having the primary impact? That's why we have to get people off of insulin. That's why we have to discontinue their sulfonylureas. That's also why we have to monitor for the reactive hypoglycemia, because they already have too much insulin on board. We then found out recently that there are the mechanisms behind it. So this was from 2018. What's the actual mechanism that's underlying all this? But it's not just bariatric surgery. There's a number of dietary approaches that have been demonstrating for the last 12 years actually work quite well in helping patients achieve normal glycemic control. So in this case, it was a low carbohydrate ketogenic diet. But there's also the DIRECT study from Newcastle University in the UK. So Roy Taylor has been doing a lot of work on this, and I'll come back to that shortly. But bottom line is that we're starting to see multiple interventions, including some organizations that are promoting dietary carbohydrate restriction as the initial treatment process. But there's even very intensive lifestyle interventions that are showing good promise. So these are increasing the amount of exercise, so it's 6 times a week, 45 minutes at a time, plus altering their dietary intake. And if the South Asian population is often a very difficult population to achieve remission in, but they were doing it within this particular study. But a real game changer happened in 2017, and this was looking at a particular study that was done out of the University of Indiana that actually spawned off a company, a business. And I want to just highlight some of the components of this. And the reason I want to highlight is really, again, about the medication changes. So this organization is now called Verta Health. It's based in the US, and they focus on delivering services remotely to support achieving remission and what they call reversal, which is normal glycemic control plus or minus metformin. But you can see in here on the side here, the insulin reductions are very dramatic. So 94% of the participants reduced their insulin dose, 48% of them came off it completely. 100% of the sulfonylureas came off, most of the SGLT2 inhibitors. This is groundbreaking in terms of demonstrating the potential role of dietary interventions. And you can see in this case, their definition, which is those that have normal glucose or normal glycemic control, plus or minus metformin, it was 60% at year 1. Again, this is a paradigm shift in terms of our understanding of diabetes remission. Now, what's interesting about this study is that it was not a randomized controlled trial. It was these patients selected to be participating in this service, so they had an interest in achieving remission. But shouldn't that be where we're focusing on, is the patients who actually are interested in achieving remission? We just want to give them an option. So I want to also cover the direct trial. So the key thing about the direct trial is that the criteria for that was diabetes less than 6 years. So type 2 diabetes less than 6 years, not on insulin. And I'll come back to this again when I talk about our study, the IPTN UBC study. They achieved 46% remission in those participants that were maintaining more than a 15 kilogram weight loss at 1 year. So you can see on the side here the particular intervention group. So for those that were greater than 15 kilograms, they had a total of 86% of those patients achieved. So I should have put 86, not 46. So 46 total, 46% of all participants, 86% of those ones that were more than 15 kilograms. So the key message that they had for this study is that remission was linked to weight loss. So interestingly, the previous one that I mentioned, the intervention, although they did have good weight loss, that wasn't a requirement in order to be able to achieve remission. So I'll come back to this again. So one of the really new and interesting things that came out of the direct study was just from last week, that remission may in fact be able to restore beta cell function. So this was a sub-study of the patients that were able to achieve remission. And you can see here that the typical loss of volume within the pancreas is roughly around 30% with type 2 diabetes. And what they found with this group that had been in remission for 24 months is that they actually had near normal pancreatic volume. And most importantly, if you look down at the bottom here, they have virtually completely restored their maximal insulin release. So what's really interesting about this is the fact that beta cell function can and potentially can be restored. And this has massive implications around the potential of remission as we move forward. So, we've been taught that type 2 diabetes is chronic and progressive, and there's really nothing that we can do about it. But we're now at a new point where even restoration of beta cell function may be possible with significant interventions that are supported over a longer period of time. So let's talk about the different evidence that currently exists. There's basically 4 trials that have shown the biggest impact in terms of achieving remission. So as you can see, the VERTA trial is looking at reversal, so it's roughly 60% in the first year. The direct trial I mentioned was 46% for those participants, total participants, more for the people that were greater than 15 kilogram weight loss. But there's also other ones that you can see here, an intense lifestyle intervention that was done looking at patients who are newly diagnosed, so 2 years, also high, both partial as well as complete remission. But I really want to focus on the top two here because of the fact that we have 2-year data now for both the VERTA trial as well as the direct trial. So after 2 years, they still were maintaining a 36% remission rate within the direct trial and 54% within the VERTA trial in terms of achieving reversal. We expect that we'll have 3-year data from both, and in fact we've got 3.5-year data from VERTA that coming out, and they're still maintaining over 50% reversal rate. So this is quite significant, especially when you look at the bottom, which is the Kaiser Permanente study, which showed that after 1 year, only about 0.14% of those participating with usual care were able to achieve complete remission. So there was a 99.9% chance that they were going to have progression. So we're talking about paradigm shifting interventions here that could completely change the way we approach these types of interventions. Now, one of the challenges are that we have not invested in nutrition interventions from a research perspective. We need to spend a lot more money researching the different options, the different intensive lifestyle interventions, the different, whether it's low carb, low energy, potential for intermittent fasting or time restricted eating. There's so many different potential options that as a health community, we need to now invest in that. So I want to talk a little bit about some of the standards of care that have changed significantly over the last couple of years. So the ADA standards of care, I'm not sure if you're familiar with the latest updates, what happened earlier this year, but they've included carbohydrate restriction as one of the elements. They've always had support for very low calorie diets, and they've looked at Mediterranean as well as other dietary options, and not supporting any specific recommendations around dietary carbohydrate restriction, except for the fact that it has been the most effective overall in terms of improving glycemia. And for those patients who choose to use low carb or very low carbohydrate diets to reduce or eliminate the need for medications, that they are the most effective at doing that. Now, there are some significant implications for pharmacists, and this is where I want to come back to what does this mean for pharmacists in clinical practice. But I first want to talk about the Canadian Diabetes Canada's position statement, which just came out a couple of months ago. And the key messages here is that it needs to include patient choice. So patients need to be at the center of the discussion. And most importantly, for healthcare professionals, we need to be focusing on adjusting medications to avoid predictable adverse events. Again, pharmacists have a key role to play in terms of medication safety. So let's talk a little bit about the study that we did. So this was a University of British Columbia study. It's currently unpublished, so I'm going to be sharing some unpublished data with you. But I think it's important for you to really understand where pharmacists are in terms of their role in this. So we wanted to check and see what was the impact of a pharmacist-led therapeutic nutrition intervention on a couple of different areas. So we used a very low carbohydrate diet, so a low carb ketogenic diet, but it was also low calorie. So this is interesting because it kind of combines the best of the direct study as well as the VERTA study. So we wanted to see, is there a potential to eliminate these glucose-lowering medications? And also, can we improve glycemic control in these patients that are using it? So the study involved many partners, including UBC, PharmaSave as the pharmacy organization. It was funded through a MyTex grant, as well as partially supported through a Michael Smith Foundation and CAHR. It was a pragmatic effectiveness randomized controlled trial. So it was being done in a community setting. We had 188 participants, 98 that were in the therapeutic nutrition group. That was part of a 12-week intervention. The direct trial is a 12-week intervention. So we were mimicking that in terms of the length of time. And we had very specific roles and responsibilities for the pharmacists. So their primary role was around safety to prevent hypoglycemia and hypotension. We also had them prioritize the deprescribing. So the physicians were not familiar with the deprescribing around the use of these types of dietary approaches. So the pharmacist would develop a deprescribing plan. They would send it to the physician would sign off on it. The pharmacist would then monitor the patients to make sure that their blood glucose was maintained, so that there were no issues with hypoglycemia. They also managed the communication with the physicians and other health professionals. So this is just a list of all the different responsibilities. So they were basically the quarterback of this particular intervention and making sure that the safety issues were being addressed throughout. This sort of gives you the first line view of how it went. So you can see the dark lines here showing the rapid descent in medication use. So typically about 75% of the insulin would be gone within the first 2.5 weeks. We actually provided the pharmacists with a slightly modified program to make it easier for them to manage the deprescribing. We refer to it basically as like landing a plane. You can land the plane by going straight down, or you can land the plane by kind of smoothly coming into the airport. And we were choosing that method. So there are often, if you hear in the literature, faster ways of doing this, but we just wanted to make it a little bit slower. So let's look at the primary outcome. So for us, we were looking at a binary outcome, which was, are they on glucose-lowering medications or not? This had never been done before, where they looked specifically at, can we get people completely off of all glucose-lowering medications, including metformin? So in our study, after 12 weeks, we were able to get over a third of the participants completely off of all glucose-lowering medications. And of the remainder, what's really interesting about this study is that any participant who was, we couldn't either collect all the data on, or if they dropped out, they were actually charted as if they had not achieved the outcome. So it was put down in the data as if they were continuing to take the medications, whether they were or not. So the challenge here is that this is the worst case scenario. So a worst case scenario is only a third of the participants were able to come off. The data would actually show, if we had more of the information, that in fact more of those participants were able to come off. We actually expected when we started this that it would be somewhere in the range between 33 and 50%. So we're right in that range. But other things that we looked at was glucose-lowering medications. So you can see on the left-hand side here, 56% of those people that were on insulin came off completely. So over half the participants came off of the insulin. Of the remaining 44%, they all reduced the amount of insulin they were taking by a significant amount. In fact, we saw almost a 93% reduction in the total dosing of insulin. You can look similar to the Verta trial. Those that are on sulfonylureas, most of them came off. Those who are on SGLT2 inhibitors, again, they came off, which is great because we have to avoid euglycemic DKA with the combination of SGLT2 inhibitors and these low-carb diets. And you can see the other ones, the GLP-1 analogs, it makes sense that they're, in fact, in some cases, patients might increase it. And metformin is sort of like a 50% reduced or eliminated, whereas the remaining of the population or the participants continued on with it. Looking at other outcomes, hemoglobin A1C and fasting glucose. So even with the dramatic reductions in medications, we still saw a 1.7% reduction in the participants in terms of hemoglobin A1C, and fasting plasma glucose also decreased significantly by 2.5 millimoles. When we look at blood lipids, cholesterol was down about 11%. One of the concerns about ketogenic diets is that there is a potential for increase in LDL. We were able to show that within our study, there's really no changes in HDL or LDL, but there was a significant drop in triglycerides, almost a 50% drop in triglycerides during that 12-week period of time. Other anthropometrics, so weight, about a 13-kilogram weight loss. Waist circumference was down about 14 centimeters. BMI was a full level down, so 5 kilograms per meter squared. So we made most of these patients no longer obese. as well as body fat also reduced significantly. So what does this study add to all of the other information that's out there in terms of diabetes remission and the potential of diabetes remission is that by combining the two, the very low calorie and the very low carb, we were able to reduce medications quite quickly while improving glucose control, which is significant. So it can really help to demonstrate the role of a community pharmacist in being that quarterback in helping patients who choose to do this, and not everyone will, but for those patients who choose to pursue remission as part of their treatment strategy, the pharmacist has a very important role to manage safety and to work with the physician on the deprescribing. So we think that this has a great potential for scale, and it's also a very innovative and novel way of using existing health resources in a new way to deliver a new outcome of remission. The other aspect of this is that because we were able to reduce the amount of insulin so significantly, that maybe there's an opportunity for those patients who are on insulin to in fact be able to get off of it completely. So imagine if we could help those patients who were on even high doses. You know, we had 270 units was the highest in the study, but I've seen more than that. One patient was taking over 800 units per day. That's just an indicator that they're extremely insulin resistant. And so wouldn't it be nice to be able to reduce the amount of insulin that patients are needing? And there's as I indicated, there's a number of different options for us to consider. So let's talk about medication safety just for a couple of minutes so I can wrap up here. There are a number of therapeutic considerations when you start looking particularly at reducing the carbohydrates. If you're going into a very low carbohydrate or the so-called keto diets, the implications on medications are quite significant. So not only the diabetes medications, but the blood pressure medications, the diuretics, and anything that's been used to manage kind of fluid overloads, CHF, other types of conditions. There's marked impacts on those populations, and we have to be aware of it, and we have to manage for it. We also have to look at electrolytes and managing the particular electrolytes, sodium, potassium, magnesium. We need to manage kidney stones, patients with gout, all that kind of stuff. So there's new and interesting kind of areas that we have to manage. But I want to really focus on the fact that the role of the pharmacist is about safety first. So looking at particularly the blood glucose and blood pressure medications, we need to be on top of this. And we have to act proactively, and we have to focus on preventing these predictable adverse events. These are medication-related adverse events. These are not dietary adverse events. And so we're really trying to address the fact that you wouldn't give insulin or a sulfonylurea to someone who had normal glycemic control. In fact, they are now achieving normal glycemic control through a dietary intervention. And so similarly, you would not give a medication to patients that have normal glycemic levels. So the biggest concern is insulin, sulfonylureas, and SGLT2s, the SGLT2 inhibitors, because of the risk of euglycemic decay. So it involves a different conversation. So, for every pharmacist, they should be having a new conversation if they are dealing with a patient with type 2 diabetes on insulin, sulfonylureas, or SGLT2 inhibitors, and say, if you are planning on changing your diet before the next time I talk to you, you need to give me a call because we might have to talk to your physician about adjusting your medications. That is a new conversation. It's never been done before. It also opens up the opportunity to now start discussing remission. I actually think that remission is, that a discussion around remission is an ethical obligation, that now that we know through a number of different studies that remission is possible, we need to be talking about the fact that these dietary approaches have shown, and leave it up to the patient to incorporate their own ethical, moral, religious, cultural, whatever the influences are. We need them to make the decision as to whether it's appropriate for them. And then we need to be there to support them. So the good news is that there's already a number of papers out there on medication adjustments. There's even some guidelines that are available through Guideline Central. So we're now getting to the point where recognition is coming that we need to address these medication-related issues. This is a summary of the recommendations that came out of the Murdoch et al. paper, just talking about the impact again on sulfonylureas and insulins. Again, we're reducing or stopping these medications to avoid predictable events. We're also adjusting SGLT2 inhibitors to avoid euglycemic DKA. And the other medication, it just depends upon kind of where the patient is. Some medications like acarbose, we can eliminate them right away because they really have no benefit. So for patients who are using a very low carbohydrate ketogenic diet, this is kind of a simple way for pharmacists to understand what to do. So this is just my traffic light indicator. So sulfonylureas, meglitinides, bolus insulin, all that you can see on the left-hand side there. We need to address that. Combination therapies, we need to address that right away. We need to transition them to basal insulin. And as I mentioned, getting rid of the alpha-glucosidase inhibitors. But for those that are on basal insulin, we may need to reduce it by up to 50% on day one. So on day one of the dietary approach, you might have to reduce their insulin by 50%. Typically, it's at least 30%, and in many cases, it's over 50%. The thiazolidinediones, just because of weight gain, and you can see on the greens there, metformin, really not an issue. GLP-1 analogs, in fact, it might help in some patients, and the DPP-4 inhibitors, really not a major issue as well. So implications for pharmacists, as I said, medication safety is the most important issue. Every pharmacist needs to be aware of this. They currently are not. And so we need to make sure that they're aware that these rapid and dramatic changes can happen and that they have a role to play in ensuring that they discuss this with patients. There are some clinical opportunities, which is also exciting. So there are a number of pharmacists, I've trained over 300 across the country, who are now starting to talk about, diabetes remission as part of their clinical services. And some pharmacies are even specializing in this. I was working with a number of groups up until when COVID started, and the roles and responsibilities of pharmacists changed quite quickly. But I was working with a number of groups on setting up diabetes remission centers across the country. So I expect that that's going to kick up into high gear once we get past the current issues with COVID. So wrapping up, remission is now a viable option for many patients. We need to be aware of that. We need to be talking about it. We need to make sure that healthcare professionals, pharmacists being an important aspect of that team, are aware of what therapeutic nutrition is, what are the implications. We need to make sure that patients are aware that medical supervision is required in order to prevent these predictable adverse events. And this is having the physicians and the pharmacists and the dietitians all working closely together to avoid problems that we know are just sitting there waiting to happen. And we think the pharmacists have an absolutely critical role in managing the safety and doing the deprescribing and delivering that transition from, being medicated to not having to worry about medication. And then there's also an important role that they can play in the monitoring and the identifying of potential for relapse management and those kinds of things. So there's a lot of opportunities for pharmacists moving forward, but we have to prepare them, and we need to do it quickly because patients are one click away from starting some of these dietary approaches on the internet, and that scares me. So we have pharmacists, physicians, nurses, and dietitians that are not aware of these implications on their medications and on their patients. And this is just a recipe for disaster. And my job is to make sure that pharmacists are brought up to speed and are made aware of this issue, and that we do have an important role to play in having a different conversation with patients. So I will stop there and give you an opportunity to ask any questions. I'm not sure how I did there. Oh, did pretty close to what I planned.
Yeah, that's perfect, Sean. Thank you so much for your presentation and sharing some of your recent research and also insights with us. So I can see Zubin's put a question into the group chat. I'll just remind our audience that if you have questions, feel free to type them into the chat box as well, and then we'll get to them after Lori's remarks. So our discussant for today is Lori McCallum. She is the Program Director of the Knowledge Translation and Optimizing Care Models at the Banting and Best Diabetes Center. And she's also an Assistant Professor at the Leslie Dan Faculty of Pharmacy. Dr. McKelvey's research has focused on the evaluation of expanded pharmacy services and medication management, including the first evaluation of the MedsCheck Diabetes program in Ontario. So I'll now turn it over to Lori to provide her remarks on Sean's presentation, and then we'll get to the questions.
Okay, thank you, Annalise, and thank you, Sean, for that amazing presentation, and congratulations for the work you've done and for setting up this institute. It's really quite remarkable, your dedication to helping patients. So as I was listening to your presentation, I was thinking, well, who wouldn't want remission and who wouldn't want to come off their medications? Because we know most patients do not like taking medications. Most people don't like taking medications. So I was thinking, you know, why isn't this the norm? And I guess looking at some of the position statements and some of the literature, one of the limitations or criticisms has often been, well, it's great you show lowering of A1C and weight loss at 3 months, 12 months. What about the long-term data? So I was very happy to see, and I haven't seen this before, that you actually showed 2-year data of remission, and you said you even have data up to 3.5 years, which I think is starting to address one of the criticisms or limitations of this type of intervention. But then, of course, one of the other questions that comes up is, it's great to lower A1C, it's great to cause weight loss, it's great to come off medications, but what about the hard clinical outcomes? If we do this, can we prevent cardiovascular disease? Can we prevent the complications of diabetes, which we know are the biggest contributor of cost and the greatest impact on a patient's quality of life? And, you know, I agree with you, to show this, you really need more money into researching these types of interventions, because it's pretty hard to compete with the drug industry and the huge pharmacologic trials, where now we have shown that drugs like SGLT2 inhibitors, which, you know, you're taking people off, are not only lowering blood glucose, but they're actually preventing heart failure and also, you know, delaying renal disease. So, you know, it's a challenge when we have that type of hard outcome data with some of these drugs, and then we have, you know, metabolic parameter data with the lifestyle interventions. So that will be one of my comments, and you can perhaps comment on that. And my second one is really about the role of the pharmacist. And I absolutely agree with you that although this is nutrition and therapeutic nutrition, we think of that generally as the role of the dietitian, that the pharmacist has to be at the table because of the risk of hypoglycemia and because of the risk of DKA with the SGLT2 inhibitors. So 100%, I agree with you. My question is around the practicality of this, because we did research recently in Ontario that we were looking at diabetes follow-up, and we knew that diabetes follow-up was quite low with the MedsCheck program in Ontario. So we looked into why that is the case and talked and surveyed pharmacists on what are the barriers and facilitators. And it came out pretty loud and clear that the community pharmacy practice environment is still a major barrier because of competing priorities, time, lack of access to labs, lack of access to the chart, and you know, just so busy and trying to do so many things that how do we now integrate something like this into what they're already doing? And how do we make sure they're reimbursed, or the pharmacy is reimbursed, so that we can allow for pharmacist preps overlap, so that you can have pharmacists dedicated to this type of thing. So I was interested to hear that, you know, there are specialized centers where pharmacists are focusing on this, but do you see a role for community pharmacists that aren't specialized having a role to play with this? And how will that work with, you know, everything else that they're trying to do, especially in this environment? So I guess that's my two things. One about the clinical outcomes, the long-term, how do we deal with that when the drugs really have those hard outcome data? And the second one is really the role of pharmacists and how you do this when they have so many other things that they're taking care of in the pharmacy. But thank you for an excellent presentation.
Yeah. Both are excellent comments, and the third one even about the sort of the longitudinal aspect of this. So, you know, I think we're at a really interesting time in that we're starting to identify the things that, in fact, we need to start looking at. So the first step in this, I think, was what are the dietary approaches that, in fact, do show that there are some potential for remission. The next part is, I think, about optimizing which approaches are going to be most beneficial under what circumstances. We're a long ways away from that. But I think the types of things that I think about when I look at you know, long-term outcomes, if you had a person who had high blood pressure, and we know that outcomes related to high blood pressure, stroke, and cardiovascular related complications, all that kind of stuff, are pretty clear. So if they have high blood pressure, there definitely are some, you know, direct complications or implications for that. Question is that if you have a person who's had high blood pressure and they no longer have high blood pressure, what are the implications? Are they still at risk of those, you know, cardiovascular related complications? Well, at this point, the belief is that there is a reduced risk. We don't know what that reduced risk is, but we know that it's reduced because that issue has now been somewhat addressed. I expect we're going to see something similar within the world of type 2 diabetes when we start addressing both the glycemic load as well as the normal sort of glycemic levels in the blood. Unfortunately, we see so many complications, a lot of vascular related complications because of hyperglycemia. And so much of this is kind of done behind the scenes, complete ignorance. You know, we just don't even know that, you know, blood sugars are as high as they are. And with people that have, you know, that are consistently like a hemoglobin A1C of 10 or 12, those kinds of things, we know for sure that the implications for them are quite significant. As we reduce our hemoglobin A1C and we get it down back into a more normal range, even if it was 7, well, we know that from a pharmaceutical targeting perspective, that's the kind of targets that we're already looking for. So what happens if we achieve that through dietary interventions? I'm assuming that we're going to probably do this type of research, but it's also going to take a lot of time and effort and money. And, you know, I would love to do a direct comparison, for example, between these dietary approaches and SGLT2 inhibitors. I think that's a perfect, you know, you're peeing out 50 to 80 grams of glucose per day. What is the difference between that and, you know, not taking it in? You know, and acarbose is a great example. You know, there was improved cardiovascular outcomes with acarbose. Problem was GI intolerance. So, you know, whether you reduce it because of a drug that is stopping the breakdown of the starchy carbohydrates, or you don't, you know, consume those starchy carbohydrates, maybe there are a number of different mechanisms involved in this. I'm really just super excited the fact that we're actually moving in this direction and that we're now talking about dietary approaches from a therapeutic perspective as opposed to just purely prevention. Because for the last, you know, 25 years, it's been how do we prevent diabetes? We're now starting to get to a point where we can now treat diabetes. And the question is, what is the percentage of those people who have type 2 diabetes that we can actually help? What is the percentage that we can give renewed hope to? Because they've been told that they have a chronic progressive condition and it's just going to get worse and there's going to be complications and, you know, surgical removal of feet and, you know, you could lose your kidneys or your eyes or those sorts of things. You know, just the fact that we can give people hope is huge. And to your point about the pharmacist role, I think it's going to be an evolving process. My first responsibility is to make sure that pharmacists are aware that this is even an issue, that we have a medication safety responsibility. So irrespective of services, a pharmacist having a conversation with a patient now needs to have a different conversation. You know, as I said in my slide there, you know, if they're planning on changing their diet, just even if they're looking at dietary approaches, give me a call. Like, I want to talk to you about that because we might have to get your physician involved to adjust some medications. that's just a new conversation that we've never had previously. It hopefully will open up opportunities to talk about remission. It'll hopefully open up opportunities to talk about different dietary approaches. It'll hopefully open up opportunities for pharmacists to collaborate much more closely with dietitians and with the physicians, because now it's a team approach as opposed to just the dietitians are the only ones that are going to be managing this. They don't have a background in medications. And the physicians that we've worked with, and we've literally worked with hundreds of them, the physicians don't have the time or the interest to do the acute monitoring and management of the medications. So we have to deal with some of the systemic issues like compensation. We have to deal with there's system-based problems. We have to deal with the fact that, dietitians aren't compensated, to be able to be part of a team like this. Some of the family health teams have started to come up with models, but it's just the access is so limited. So we have to change things from an episodic model of care where it's about acute, issues. Like it was built around broken legs and cut fingers, not around chronic care, continuous care, longitudinal care, relapse management, those sorts of things. So I think we can learn a lot more from tobacco cessation and the models that evolved from tobacco cessation than really any other type of model that's out there, because we're going to have to do this over and over and over again potentially to get the person to the point where they actually achieve that level of either management or remission that they're wanting to achieve. But as health professionals, our job is just make sure that it's being done safely and that the patients are supported. And now that we have the evidence base to say that these are options, we need to make sure that the clinicians are prepared for the potential negative consequences of some of these dietary approaches in combination with medications. And that's the key message. It's in combination with.
Yeah.
So I'm not sure if I answered all your questions, but I tried.
And when you say, just for people in the audience that may not know, when you use SGLT2 inhibitors, which are very much being promoted for not only their blood glucose lowering, but their cardiovascular effects, we advise don't use them if you're on a low carb diet because of the rare risk of a very serious adverse effect called diabetic ketoacidosis. So for those of you who weren't aware, so it is very important.
It's euglycemic too. Yeah, it's euglycemic. So their blood glucose is normal. Like normally with DKA, their blood glucose is crazy high. In this case, it's normal. In some cases, it's even low, and they still have DKA. So that's the issue with the SGLT2 inhibitors.
I was thinking of smoking cessation too, because I used to run a smoking cessation clinic when you were talking, and you just mentioned it now, and it's getting those patients that are motivated. You said that a few times, that you're not telling everyone to go on a low carb diet. These are patients that are interested, and I was wondering what the dropout rate has been, because with any lifestyle modification, we know that persistence is really difficult, for everyone. So what has the dropout rate been for patients that are doing this type of intervention?
That's another great question. The dropout rate always depends. Dietary interventions have been notorious for having extremely high dropout rates. And depending upon the type of intervention, the dropout rates can be as low as 5% to as high as 25, 30%, but much better than the 50% dropout rates that have kind of been in previous interventions. And I think the difference is that when people see the reduction, the immediate reductions in medications, and the fact that, I was told that I was going to be on this for the rest of my life, and I was just going to be increasing the doses. Those folks that are on insulin in particular, when they come off, it's like they've had a renewed lease on life. And it's like, I never want to go back to there again. We cannot underestimate the burden of treatment. It is absolutely, it's a 24/7 constant 365-day issue that these patients are having to deal with. And when they are no longer having to take those medications, it's like this dramatic change. It's like their mood changes. They become so much more enthusiastic about exercise and so many other things, because now they feel like they have control again, which I think that more than anything, when I talk to the clinicians who are doing this in practice, whether it's physicians, pharmacists, or dietitians, they all have the same response around, it's made their practice, like it makes it totally changes their own personal beliefs and how they feel about what they do. We've always wanted to make a difference and help patients. They actually now see that they are giving people hope, and they're giving them options for them to consider. And if they choose not to do it, well, that's a choice. But to not offer it, I think is now to the point where it's becoming an ethical obligation for all healthcare professionals to have this new conversation. But you first have to be aware, and you then have to talk about how do you do this. And most clinicians, whether it's physicians or pharmacists, are not in a position to be able to deal with that right away. And the other part of it is that there's just not enough dietitians. We've got 12,000 or so that we're dealing with across the country here. And if you've got, 11 million people that could benefit, that have metabolic related health issues, there's just not enough. And so we have to find ways of using technology. We have to find ways of using existing providers. We have to find ways to use technology that allows for the scaling of these services. It's going to be a all hands on deck kind of an approach. And the dietitians, I think, are going to be absolutely critical in the future. But we have to do this in partnership. We have to work with the pharmacists and the dietitians and the physicians all to collectively. Otherwise, patients are going to get hurt.
I see Annalise is back. I just want to, sorry, Annalise, I have
no,
question about dietitians, because dietitians that I've encountered are split on this issue of low carb diet. Some of them are, I would say, almost against it, and they're still about Canada's food guide and the 45 to 60% carb. In fact, a lot of them have been against low carb diet or any dietary, I know you call it dietary pattern versus diet or eating pattern. So when you say we need more dietitians, but do you feel that they're split on the issue of the low carb?
Well, I think with any emerging science, practice change is an ongoing process. And, we did a survey. So we worked with UBC on doing a national survey of dietitians, and we had over 220 or so dietitians provided feedback. The issue is not necessarily adamantly against it. Yes, of course, like everything, there's going to be certain voices that are against, there's a large percentage of dietitians that are against weight loss. So if we're looking at this from a practice change perspective, it involves evidence. So the evidence is now clear. It involves an understanding of what their role is going to be. They have not been trained in using, whether it's very low calorie or very low carbohydrate diets with their patients. So there is a training requirement. So we're going to have to build these educational modules to help dietitians get up to speed. That's what we've been focusing in on. So we have now, we're just finalizing our physician training program. We've already been doing a pharmacist one. It's being adapted now for online training purposes. We're also working towards having the dietitians, where they can get the access to the knowledge. We're setting ourselves up as being the trusted and credible source for information on therapeutic nutrition, so that dietitians know that when they do get the information, that it's not just off of some website off the internet, that in fact it has been vetted. The resources and the tools are consistent with what is going to be required, as well as, it addresses the issues that they often are struggling with, like fiber content and those kinds of things. So, and they also worry about, keto diets, for example, it's about bacon and butter. Well, no, it's not. The ones that we're talking about for the therapeutic, use are not that. But it's just, unfortunately, perceptions, particularly in the lay press, have led to a situation where they're questioning the potential application of some of these dietary approaches. And it's natural, it's to be expected, especially when, I think dietitians in particular have been struggling to to show their value in the healthcare system in the midst of everyone basically making themselves, look like they're a nutrition expert.
Right.
So I get it, but we just need to tap into that, the expertise that they do have, and we need to support them and provide them the tools. And I expect that they're going to be working, very closely with pharmacists and physicians and nurses and other healthcare professionals, and filling a gap that is just not going to be filled by those other healthcare professionals. Building these dietary the meal plans and these specialized approaches, especially with people who have a history of eating disorders, or if they have a history with GI intolerances, or whatever the case may be, food allergies. Dietitians are fantastic at building meal plans that are nutritionally balanced, that can be used for these types of therapeutic interventions, but you just have to support them in getting to that point, and we're working on that.
Thank you.
Thank you both. I feel like that kind of answered Zubin's question. A lot of your comments there at the end, Sean, answered Zubin's question about kind of your approach and the tools that you're using in our multicultural society. But I would also say where we have a lot more sensitivity to food allergies and eating disorders and that sort of thing. So I think we kind of got to that question, and then also touched on the importance of really cross-disciplinary healthcare provider team that's working with the patient and engaging the patient in a lot of their decisions. So I would like to say a big thank you to both Sean McKelvey and Lori McCallum for acting as our presenter and discussant today. A lot of great feedback. I have been recording the session, so it'll be available afterwards. And just for our audience online, our next CPE speakers event will be taking place on November 5th. So please stay tuned for information that will be coming out about that. So just on behalf of myself, Zubin, and Lisa at the Center for Practice Excellence, a big thank you again to Sean and Lori for their presentations today.